Welcome, everyone. I'm Dick Deming, Medical Director of Mercy One Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. Our topic this evening is gynecologic cancer, and my guest is Dr. Michael Goodheart, Gynecologic Oncologist at the University of Iowa. Welcome, Michael.
Thank you. Thank you very much. It's great to be here. I appreciate the invitation.
And as we were saying before the program started, it's very timely because September is Gynecologic Cancer Awareness Month.
It is. It is the whole month. So this is perfect, and I again appreciate the invitation.
Well, before we get into the topic, let's get to know you a little bit. So, where are you from originally? Where did you grow up? Grade school, high school days?
Sure. Yeah. So you probably can't tell by my voice, but I'm originally from the state of Louisiana. So I was born in Baton Rouge, Louisiana. Grew up there probably until I was maybe in grade school, junior high, and then moved to North Carolina. I went to high school in North Carolina. I went to college and medical school in North Carolina, and then I went back to Louisiana to do my residency, and then matched here at the University of Iowa for fellowship. And believe it or not, that was 25 years ago, and have been here in Iowa ever since. I'm an adopted Hawkeye, so I got rid of all my LSU apparel, and well, I keep one or two things, but my LSU apparel is gone, and I just have a black and gold in my wardrobe right now. So,
all right. Do you still know the song that is it Michael? What's the name of the tiger? The LSU Tiger.
Oh yeah. Oh boy,
There's
I
a
should
fight
know that,
song.
shouldn't I?
Okay, I won't put you on the spot. So,
Yeah.
So
I
I'm
know
always
hockey though.
fascinated how people, end up being what they are when they grow up. There's so many forks in the road that we have. So, in high school, what was your claim to fame in high school?
Well, so I was a pretty big nerd in high school. So I really liked science, and knew I wanted to do something science wise. I did some sports, but wasn't all that great at them. I went to a pretty big high school in North Carolina. So when I got into college,
And
uh,
which college did you go to
yeah,
in North
I
Carolina?
went to college at NC State, which is in Raleigh, North Carolina.
Mhm.
And I originally was going to start out and have a degree in chemistry. So I was originally going to do sort of like drug discovery. I really liked organic chemistry and synthesizing. I thought I was going to, discover some interesting drugs and things like that. But as I went along, I had a lot of friends that were in chemistry with me, and they were all like, "Hey, we're going to medical school. Come to medical school. Let's go to medical school." And I was like, I don't know. But they were all applying. They were so enthusiastic, and I really liked them. I was like, okay, I'll apply to medical school. So I applied to medical school, and lo and behold, got in. So,
And which medical school?
yep, I got into East Carolina University, which is in Greenville, North Carolina, the
Okay.
Pirates. So I attended East Carolina, and then
So
finding
in medical school,
yeah.
which were you the type of medical student that liked everything and couldn't decide what, or did you pretty much know you wanted like a surgical specialty as opposed to a medical specialty?
Yep. So I'll tell you a quick story. So I was the former. I loved everything. Every rotation I went on, I was like, how in the world am I going to decide? Until one day I was walking home because I lived in walking distance from the hospital, and I was cutting through the emergency room. And I'll never forget, this was when I was a second year medical student. The first 2 years back in the day were book work, and then the last 2 years were clinical. So I had not seen a patient, interviewed a patient, seen an operation, nothing. It was just pure book work. And I was cutting through the emergency room, ran into one of my upperclassmen, and he was like, "Hey, we're going to take this patient to the operating room." And I was like, "Well, I've never seen an operation." And he was like, "Well, let's fix that right now." And I was like, "Really? I can go?" And he goes, "You're a medical student, of course. Come on." So he got me a pair of scrubs. I put them on, and I remember it like it was yesterday. I went into the OR completely petrified, and I just remember I loved everything. And they operated on this person, got them under anesthesia, did the operation, it was a successful operation, woke them up. And I was just like, I just could not. And even to this day, I am still amazed at surgery and all the things and all the benefits that we can help patients with through operation. So right then and there, the surgery bug bit me,
Hmm.
and then it was kind of like, well, what kind of surgery do you want to do? But I knew right then and there that I want to do something surgical.
Okay. And then did you have, as you're going through your training and deciding to go into OBGYN,
Yep.
you like this joy of delivering babies, of bringing
Yeah. So
life?
I thought, but that quickly faded.
Okay.
So not that it's not a joyous occasion, don't get me wrong, but yeah. So I was kind of vacillating between surgery and OBGYN, like I think a lot of medical students who are interested in surgical kind of procedures do, and I settled on OBGYN because again, I thought, wow, I could deliver some babies, I could take care of patients long term. I just thought it would be a nice variety. So then I started my residency at LSU in New Orleans, and pretty quickly came to realize that what I really had a passion was for doing surgery. That's what that really I enjoyed, and I definitely enjoyed seeing the moms and delivering the babies. But really, really my passion was in GYN cancer surgery, and thankfully rotated on the GYN oncology service early in my medical or my residency training, and just I meshed with them, they meshed with me, and it was just a match made in heaven. And then that's kind of just no looking back after that.
Right. And for those who don't know, to become a gynecologic oncologist, you've obviously gone through medical school and then you go through a complete OBGYN, obstetrics gynecology residency. And that was 3,
4
4 years?
years. Yep.
4 years.
Yep.
And then you go into a fellowship, and that is 3 more
Correct.
years. And
Correct.
as you said, you came to Iowa for your
I
fellowship in gynecologic oncology.
I did. Yep. I came here and
Were
just
you
matched.
a little bit afraid of crossing that Mason-Dixon line? Did that
I
cause
was,
some
and
trepidation?
to be quite honest, I was probably like most people, a little bit confused with Iowa, Ohio, and Idaho.
Oh,
Now I
you really
definitely
wanted to
have
go to
them.
Ohio State, and you got
Oh my, no, would
actually, just
never.
a quick aside, you'll just I have a friend who is from Japan, and she came to college, so she'd gone through everything. And one of the things she absolutely wanted was to be in a state that had snow skiing, and they sent her to Iowa thinking they were sending her to Idaho, and she ended up. But anyway, you did know by the time you got on in your car to drive that you were going to Iowa, not
I did.
Ohio.
I did. So I
Okay.
came here to Iowa and have been incredibly happy the entire time. Just couldn't be more satisfied. The Iowans completely adopted me and accepted me, and like I said, now I have nothing but black and gold in my wardrobe and cheer on the Hawkeyes, and have just really had a great time here.
So tell us a little bit about fellowship. What does that entail, besides learning, and getting experience with very complex surgeries? You also, gynecologic oncology is one of those specialties where you're kind of a combination of a surgeon and a medical oncologist,
We
and
do. Do you want
and you probably also had to do some research as part of your fellowship.
Yeah, that's a really great question. So, as GYN oncology is probably the only specialty that I know of in which the surgeon both operates and administers chemotherapy. So, we're trained in all the complexities of doing big, ovarian cancer surgeries and uterine cancer surgeries, lymph node dissections, splenectomies, bowel resections, the whole gamut of surgical intervention to treat and hopefully try to cure women with GYN cancers, but then we also administer our own chemotherapy, which is kind of nice because that way, when somebody comes in, we can really decide, is surgery the best or chemotherapy the best or some combination thereof. So you learn all about the different types of chemotherapies and how to administer them and all the side effects and complications. And then that's a 2-year commitment as far as clinical work. And then the last year, the third year, is research. So we do one solid year of research where we typically, but not always, would work in a laboratory doing basic science research. We're paired up with usually a PhD who's investigating some kind of GYN cancer, and then we go ahead and work with that individual. And then at the end, that produces a paper. And then along as you're going, you write some abstracts and submit those to meetings and everything like that. So I think,
Michael, what was your research project? And I think we're talking about 25 years ago. Is that right?
yeah, probably about 20 years ago. Yeah.
20
So I
years
did
ago.
my research project on women with ovarian cancer, and that had a special genetic mutation called a BRCA2 mutation, and looked at, did those women that had this BRCA2 mutation, depending upon the kind, did they survive longer? And if so, why? So that's what my research was on. So.
Okay. One of the things I always wonder about you as a gynecologic oncologist that does very complex surgeries and chemotherapy is, my gosh, the number of new agents that are coming, the new chemotherapy drugs, targeted therapy drugs, immunotherapy drugs. How do you possibly keep up on everything and do complex surgeries as well?
Yeah, that's a really good question. And I would say, thank goodness the surgical interventions and the new techniques in surgery are not many. In other words, most of the surgeries that we did today, we did when I was a fellow. So there's not a ton of new surgical interventions. There's a few here and there. But you're right. The chemotherapies it seems like every time you turn around, there's a new chemotherapy coming out or a new indication for something. So that's something you really got to kind of stay on top of. And it's kind of nice to have a fellowship. We have a fellowship here at the University of Iowa. And anybody that's been around a learner certainly knows they are happy to ask you questions. And it's good that they ask you questions, but that really helps keep us on our toes and everything. So they definitely help with that. And then, we attend, our national meetings and regional meetings to kind of get information on. So, and then we have a monthly journal club where we review articles and things like that. So, but you definitely have to stay on top of the chemotherapy. That's an
Yeah.
ever-changing field.
So one mechanism of coordinating care for patients is something that we call tumor boards or multidisciplinary cancer conferences. I'm just curious, at the University of Iowa Gynecologic Oncology multidisciplinary conference, your tumor board, do any medical oncologists also participate in that besides gynecologic oncologists?
They do. So we have some medical oncologists, and they may not attend, regularly, but they definitely drift in and drift out. And then we have radiation oncologists that will come. So yeah, we have a wide variety of people that will sort of drift in and drift out. Nobody specifically that comes every single solitary time, but
Mhm.
they're pretty well attended as far as all the faculty come, all the fellows come, all the residents that are rotating on our service come. We have 4 mid-level providers; they usually come. So
Right.
it's a pretty packed room actually. So.
And the reason I asked about medical oncology is there is a real shortage of gynecologic oncologists. So, in many communities, the chemotherapy for gynecologic cancer is done by conventional medical oncologists, not by gynecologic oncologists. So, I'm
Right.
sure the fellows that are in the medical oncology program there at the University of Iowa need to learn about treating gynecologic cancers as well.
They do, and actually they rotate on our service usually about a month to 6 weeks, sometime during their fellowship. So their fellowship is a 3-year fellowship as well. And then sometime during that rotation, or sometime during that time, they would rotate on our
Mhm.
service, usually for right at about a month or something. They would come to clinics. They would come to our tumor board, come to our journal clubs. I mean, they're a real integral member of our team during that month that they're on our
Do you
service.
make them tie knots in the
No,
operating
no,
room?
that they don't want to do any of that. And I
No.
always offer for them to come to the OR, but I have yet to have a taker for that. They'd rather kind of do their own thing, stay in their own
Okay.
lane, which is fine with me. So
And you did mention, that obviously the medical oncology part of gynecologic oncology, all sorts of new drugs all the time, but the surgery hasn't changed a lot. A question I would have is, did you learn in your residency or your fellowship robotic surgery? Does robotic surgery, is that something you grew up with, something you acquired, or what role does robotic assisted surgery play in gynecologic oncology?
Yeah, that's a great question. So when I was going through fellowship, we didn't do a lot of robotic surgery. But when I became a faculty member, one of my early partners, Dr. Bender, was really the one that got the robotics program working up and running here at the University of Iowa for G1 Oncology. And he was just a very interested in robotic surgery. So he kind of took that route. And then I kind of did the laparoscopic surgery. So I do, the majority of my minimally invasive surgeries laparoscopically, and he does the majority robotically. So it's kind of a nice complement. That's why fellows and residents and the medical students can kind of see both ways. And then a lot of the partners kind of do a hybrid. They do a little bit of both. So each platform is really specific for something different, and they're both minimally invasive. So that's really nice for
Yeah.
patient care, things like that.
And that's maybe the one of the biggest changes in surgery in general is the various minimally invasive, whether it is laparoscopic or robotic or other ways of doing minimally invasive in parts of the body, but it certainly has led to faster recovery time for patients to get back to their full activity.
Yeah, absolutely. And I would say the big thing was the concept of sentinel lymph node mapping. So we used to, back in the day, do a full lymphadenectomy. So remove all the lymph nodes in the pelvis and then up higher under the bottom part of the aorta for whenever we did lymph node dissection. Now, especially for endometrial cancer and even cervical cancer patients that we operate on, instead of removing that whole lymphatic chain, which increases operative time, increases potential complications, and really can increase the lower extremity swelling called lymphedema in patients. We now do what's called sentinel lymph node mapping, which is where we would inject a certain dye, a special dye, into the cervix, and we want to identify that first draining lymph node. And then we remove that. So instead of removing, I don't know, 8, 10, 12, 15, even more lymph nodes from these anatomic boundaries, we now just remove one from the right side and one from the left side. So what that does is that one, decreases operative time, two, decreases the complication rate, and then three, decreases the probability of lower extremity lymphedema. And the concept behind that is, I'm sure you probably know, and maybe your audience does, if that first draining lymph node is negative, then all the subsequent lymph nodes beyond that should theoretically be negative as well. So it's
Right.
definitely been a big surgical, move forward, and I would say definitely has helped patient care tremendously.
So I have to admit, I'm obviously very familiar with sentinel lymph nodes, and it's been used for a long time in breast cancer. So
Right.
when you do it in gynecologic, do you do it for cervix or uterine cancer? You would ovarian cancer wouldn't be applicable to that, would it?
Right. Typically, it's not done for ovarian cancer, but uterine and cervix for sure.
And so most of the time when I see the path reports, there's a lot more lymph nodes than just one on left and one on right. But when you do the sentinel node procedure, you typically get one or two or three or
Yeah, correct. And sometimes it's a little bit difficult to really differentiate, are you taking just solely one lymph node out, because they are kind of clustered together.
Mhm.
Um, but you're definitely not taking 15 or 20, which is what, we would normally do back in the day. So, anywhere between, 1 to 3. And sometimes you just can't tell because they're, again, all sort of clustered together in a little packet that lights up bright when you're doing the surgery. So you just take that little packet out. And again, the pathologist then sort of teases out, is
Mhm.
it 1 or 3 or 2 or whatnot.
Yep.
But again, the general concept is just to not take all of them out.
Yep. Right. And it reduces the side effects, and as you mentioned, lymphedema and probably recovery time as well is improved.
Everything is improved. Yeah, it's been a really, I would say that's probably one of the biggest surgical advances in our field that has happened within the past, maybe 10 years or something. It's really been very nice for
Good.
patients.
Let's talk about the various gynecologic cancers. And there's only one of the gynecologic cancers for which we have validated screening for, and that is cervix cancer. And cervix cancer screening has been around for a long time. Typically, pap smear to look at the cells on the cervix to see if they have any atypia or frank malignancy. And now part of the evaluation can also include looking for HPV virus. So maybe let's start with cervix cancer. I invite you to say more about screening, and then a little bit about who's at risk, what are the risk factors for cervix cancer, and just a little bit of the general treatment philosophy for cervix cancer.
Yeah, that's a great way to start it off. So, yeah, you're right. We definitely do, of all the GYN cancers, the only one that we have a approved screening for is cervix, and that's with the Pap smear. And then we typically always test that for HPV, human papillomavirus testing as well, because we know that there are certain strains of HPV that put a patient at a little bit higher risk for the development of cervical cancer. So we have sort of like these high risk subtypes of HPV and low risk subtypes of HPV. So typically when we do a pap smear, we would go ahead and send that for what's called co-testing, which is where they would go ahead and test that for HPV. And then it will also tell us the subtypes that they have. And then based upon that, excuse me, we would go ahead and, you know, sometimes we would need some further evaluation, some further testing with some biopsies. And that's usually done via what's called colposcopy, which is where we look at the cervix with a little bit of a finer detail with what's called a colposcope, which basically magnifies the cells around the cervix. And then if we see anything negative, abnormal, then we would go ahead and biopsy that and sort of go from there. That's usually the way that the evaluation for screening and for then working up and evaluating an abnormal pap smear would go. And then again, hopefully with universal screening, we would be out of business for cervical cancer, which would be, I think, fine with most G1 oncologists.
Right. Not only universal screening, but HPV vaccinations to prevent.
So another great point. Thank you very much. You literally took the words out of my mouth. So there is a vaccine, what's called a multivalent vaccine, which can vaccinate the person against the known high-risk subtypes. So we clearly have identified a handful of high-risk subtypes of HPV, and they've packaged that into a shot for a vaccine. And the side effects are incredibly low. And the vaccine is like 99.7% effective. It is highly effective, not only against the prevention of cervical cancer and cervical dysplasia, but also genital warts and things like that. So I would say it's definitely worthwhile to do. You're supposed to get the vaccine, before an individual becomes sexually active. So usually they start that, by the pediatrician at a, relatively young age, just to be sure. And it's just should put us out of business between that and the pap smear screening, but unfortunately hasn't. There are a lot of different reasons why people are not vaccinated or don't get their screening. But we're here to take care of them no matter what.
So let's say that you have now made a diagnosis of cervix cancer. Sometimes it's not symptomatic and you pick it up on screening, but sometimes it is symptomatic. What would be the most common age, and what are the most common presenting symptoms of cervix cancer?
Yeah, that's a great question. And cervical cancer is kind of has a bimodal age of presentation. So usually we see patients, in their 40s and 50s, and then there's also another age bump, around in their 60s. So, and the most common presenting symptom would be abnormal bleeding. So I would say that, anybody with abnormal bleeding, should be definitely evaluated, and especially postmenopausal bleeding. So if somebody's gone through menopause, gone through the change of life, stopped having periods, and then all of a sudden has bleeding, that's definitely not normal, and that should be evaluated by, maybe not a GYN oncologist at first, but definitely a general gynecologist for evaluation, physical examination, and then maybe an endometrial biopsy to evaluate for endometrial cancer, and or a pap smear to evaluate for cervical cancer, or just a examination to look to see if there's any abnormalities of the cervix.
Yeah. And you mentioned endometrial, so why don't we bring that into the discussion, and maybe
Sure.
for those who don't know, explain the anatomy of the uterus and what's the endometrium and what's the
Yeah.
cervix and kind of the difference between those two cancers.
Absolutely, absolutely. So the cervix is actually the opening to the uterus, and it's what would keep a developing baby sort of inside. So it's just a circular bustle there that keeps that is the opening to the uterus, and then inside the uterus you have the endometrium, and that's actually where a baby would grow. So in cervical cancer, that can be visualized through a pelvic examination. After you place a speculum, you would just look straight at the cervix, and then you could tell if there are any abnormalities and biopsy those or perform a pap smear. And then endometrial cancer is usually a cancer that develops from the inside lining of the uterus, which again is called the endometrium, and that's where the developing embryo or child would develop, which is inside that endometrial lining. So most people would think of sort of the cervix as a round circular area that you can see on pelvic exam, and then they usually talk about the uterus being sort of a pear shaped. It sort of looks like it has a little bottleneck, and then it kind of balloons up at the top. So, but again, the cancer would develop usually inside that endometrial layer, and you can take a biopsy of that just right through the cervix, and we do that in clinic, all the time.
And correct me if I'm wrong, but in the United States, there are many more women with uterine cancer than with cervix cancer nowadays. Is that correct?
Absolutely.
Yeah.
Absolutely. So
Yeah.
endometrial cancer is the most common type of gynecologic malignancy and is the fourth most common type of cancer in women. So
Mhm.
so it's very, very prevalent. There are we see a ton of cases of endometrial cancer, here at the University of Iowa.
Yeah. So let's talk about then cervix cancer in terms of treatment.
Yeah.
So let's talk about early stage cervix cancer.
Yeah.
Cervix cancer is one of those types of cancer that can be multimodal in terms of utilizing surgery, chemotherapy, and/or radiation therapy. All three modalities are used sometimes in cervix cancer. What would you say? How would you summarize the way in which cervix cancer is treated?
Absolutely, absolutely. So typically, as a general rule for early stage cervical cancer, meaning that the cancer is just confined to the cervix, we would offer that patient an operation. And that operation is called a radical hysterectomy. And then usually we do that through an abdominal incision, and we would take out the uterus and the cervix as these two things are combined. And then, depending upon the patient age, we may or may not remove the ovaries. We would take out the fallopian tubes, and then we would also take out the lymph nodes there in the pelvis. And that operation is designed to hopefully cure that individual that has early stage cervical cancer. And then we would send all of this to the pathologist. They would look at it under the microscope, and then depending upon any kind of high risk pathologic features that we would find on the histology specimen after the pathologist looked at it, then we would decide, does that patient need additional therapy? And if so, then that therapy usually would consist of either chemotherapy, radiation therapy, or some combination thereof. Um, for advanced stage cervical cancer, we tend to use a combination, like you had alluded to, about a combination of chemotherapy and radiation therapy given together. And that's usually given, and not to steal your thunder, as I know this is your area of expertise, but the radiation treatments are usually given daily, Monday through Friday, and usually for about 5 to 6-ish weeks. And then they get, concomitant chemotherapy that is usually given through the vein weekly to help the radiation work better. And then for metastatic cancer that's gone beyond the pelvis, lots of times we'll give additional chemotherapy to treat somebody if they have, lung metastasis or something like that, disease that's outside the pelvis. Those are often treated with a combination of chemotherapy and radiation up front, and then we give a little bit of extra chemotherapy toward the end to help with that.
And then let's contrast that with endometrial cancer, and what are the standard treatments for early or late stage endometrial cancer?
Yeah. So almost all patients with endometrial cancer will be offered an operation up front as long as they're a good surgical candidate. And that would consist of some minimally invasive removal of the uterus, cervix, tubes, and ovaries, so a complete or a full hysterectomy. And then again, we do that sentinel lymph node mapping where we take a lymph node from the left and from the right. And then based upon the histology and different risk factors, we would sometimes then decide, does that patient need additional chemotherapy and or radiation? With certain patients, if we knew up front that they had enlarged disease or enlarged lymph nodes or disease in what's called the omentum, which is a little fatty apron that hangs off the colon, then we would, obviously remove that, because the goal of all these operations is really to try to remove all of the cancer that we can visibly see. So oftentimes we'll employ CT scanning before we do the surgery, and that will give us sort of like a little bit of a roadmap to know, okay, we need to pay particular attention to a lymph node in this area because it's a little bit enlarged and we would like to remove that as well. And then again, afterwards, we would either give a combination of chemotherapy and or radiation, depending upon the stage and the type of cancer and where it actually is within the body.
Okay. And now let's go to ovary and fallopian tubes. And we could spend 3 hours on this. This is a pretty complex topic.
We
And
could.
yeah, but we're only going to spend 15 minutes because I want to leave 15 minutes to questions, because we've got a large studio audience here.
Sure.
And I can tell they are chomping at the bit to ask you questions. But before we do that, so ovarian cancer, sometimes called the silent killer, because it often doesn't have symptoms till it presents in advanced stage, when the cure rate is not nearly as good as early stage cancer. So maybe give us a little primer on ovarian cancer.
Yep, absolutely. So, and that's a great segue into this. So, I would say oftentimes with endometrial cancer, the presenting symptom is postmenopausal bleeding. Most women, if they've gone through the change of life and have abnormal bleeding, they know something is wrong and they seek medical care. And I would say kind of the same for cervix as well. I would say for ovarian cancer, the problem with that is number one is no good screening tests. So we have no way to screen for women with ovarian cancer. And number two, ovarian cancer tends to kind of develop slowly. And the symptoms are very vague. So once you know somebody has ovarian cancer, if you go back and really, dig deep and ask the patient, a lot of questions, then they'll say, oh yeah, I did have some bloating, or my pants didn't fit. I had a little bit of difficulty getting the button buttoned, or the zipper zipped, or the belt attached at the same hole. It just kind of wouldn't fit very well. Or they have what's called early satiety, which is where they just get full very fast. Or they might have some changes in their bowel or bladder habits. But, most of us will have something sort of like this from time to time. Sometimes we just eat something that doesn't agree with us, or we just don't feel hungry for one reason or another. So the problem with ovarian cancer is, number one, there's no good screening test for it. And then number two, the symptoms are incredibly vague. So there's not one symptom that just stands out and is like, aha, if you have this symptom, then you definitely need to go in and be evaluated for ovarian cancer. So the problem with that is that oftentimes these cancers can grow unchecked for quite some time. And I think, of the patients that I see, oftentimes they feel, very sort of guilty that they should have, known or should have done something. And that's just obviously simply not true, and I oftentimes use the analogy, well, every time you have a headache, you don't go running to the neurosurgeon thinking that you have a brain tumor. You just assume, I had a stressful day at work or a stressful day at home or something. You take some Tylenol and you move on with life. So, it's kind of one of those analogies that the symptoms are just so vague that it's very hard to say, okay, when I have bloating, I have ovarian cancer. That's just not the case, 9 times out of 10.
And so, how do you make the diagnosis of ovarian cancer?
Yeah, that's a great question. So usually there has to be a very high index of suspicion. And then usually what will happen is somebody will, have an appointment with their primary care specialist, and they will either get an ultrasound or a CT scan that will then identify. There's some very classic findings on CT scan especially. And then there is a blood tumor marker called a CA-125. And I just want to make sure that everyone knows that it's not a screening test. So we don't screen patients with the CA-125 because it can be elevated for lots of other reasons besides an ovarian cancer. So there's a myriad of reasons why somebody may have an elevated CA-125. It is also notoriously a poor test for women that are premenopausal. So the women that are still having their period. It's usually a little bit more reliable for women that are postmenopausal, and then have a high index of suspicion for ovarian cancer. So let's say somebody has some early satiety, they get full after eating just a little bit, they have some bloating, maybe some change in their bowel habits, they go in to see their local doctor. That person then CT scans them, and there's a pelvic mass and some other findings that are suspicious for ovarian cancer. And then that would be the appropriate time to draw the CA-125, which again stands for cancer antigen 125. And then if that test is positive, then that's very worrisome for a diagnosis of ovarian cancer. And then that patient is usually referred in to see us.
Yeah. And so typically, correct me if I'm wrong, surgery and kind of a large surgery, an exploratory surgery and removal of all of the cancer you can see, that's often the first step for ovarian cancer, correct?
That's absolutely correct. So I would say, the majority of the time we will offer patients what's called surgical cytoreductive surgery, which is where we put them under general anesthesia, make a vertical up and down midline incision, and obviously remove usually patients will present with an enlarged ovary, so a big pelvic mass, and we'll remove both tubes and ovaries, do a complete hysterectomy. And then again, ovarian cancer tends to spread to the omentum, which is again a fatty apron that lies in the upper part of the abdomen and sort of hangs off the transverse colon. So we go ahead and remove all that omentum. And then really we use a CT scan as our guide, as well as looking. And there's just a systematic approach that we look left to right, top to bottom, and go through the whole abdominal cavity, literally inch by inch, and try to remove all the little specks of tumor, any enlarged lymph nodes, any kind of tumor implants that we see. We would like to remove all those. And that's called cytoreductive surgery. And the goal with that cytoreductive surgery is to render the patient with no visible disease at the end of the operation. That's what we would like to do.
But sometimes you're not able to do that, and even before you close the patient up, you know that you haven't removed every bit of the cancer,
That is
and that
correct.
comes into, we might talk about second look surgery. But after you do the surgery, most patients go on to receive chemotherapy, either adjuvantly or because you know that they have residual disease, correct?
You absolutely are correct. So I would say probably 99.9% of patients that have an operation are then going to go ahead and have subsequent chemotherapy. And that's medication, as most people know, given intravenously through the vein to kind of help clean up any residual disease that's left behind. Now, I will say that if we see patients and look at their CT scan, there are some instances where we decide not to offer them surgery up front because they're either not a good surgical candidate. We also have, unfortunately, a lot of patients have blood clots in their lungs or blood clots in their legs that, in operating on somebody after they've been put on something that's in their blood, we don't want to take them off that blood thinner if it's a brand new diagnosis of a blood clot. So in those situations, or if we just don't feel like, based upon the CT scan findings, we'll be able to get all the cancer out because it's either wrapped around something that we just are unable to remove, then we'll give those patients chemotherapy up front. So we'll go ahead and typically get a biopsy of something just to confirm the exact type of cancer that it is. And again, to confirm that it's a cancer. And then we'll usually give them about 3 or 4 doses of chemotherapy up front. We'll re-CT scan them and then offer them an operation. And again, the goals of that operation at that time would be to get all the cancer out. And usually by that time, some time has passed. It's safe to take them off of blood thinners if they have a blood clot in their lung. And then again, the cancer will have hopefully shrunk down away from any areas that it was that would have made it non-resectable at the initial evaluation. It will then become more resectable. And then we go ahead and remove all that disease. Once we're done with the operation, we get the patient recovered, and then we usually give them, 2 to 3 to 4 cycles additional chemotherapy after that surgical intervention. So it's kind of like a sandwich. It would be chemotherapy, surgery, and then more chemotherapy.
And very complex. And as you pointed out, how they respond to one treatment or what you were able to accomplish determines what the next treatment is. And then there's reevaluation. Where do we stand now? And sometimes you go back for what's called a second look operation, correct?
Sometimes. So what we typically would do is once that patient has been in some form or fashion operated on and then administered chemotherapy, there are some maintenance therapies that we occasionally will employ. And there's a new class of drugs that are relatively recent called PARP inhibitors. And those are oral medications that are used to decrease the risk of patients' cancer coming back. So lots of times we'll put patients on a maintenance therapy. And then again, as many know, that unfortunately there is a very high propensity for this kind of cancer to recur. And then at that time, depending upon when the cancer recurred, where it recurred, then sometimes we'll offer that patient another operation to remove any sort of residual disease. And then again, more chemotherapy. So it's kind of just a repetitive cycle. And what we'd love to do is get patients, some cancer-free time in between there. But again, there is such a very high rate of recurrence. But I would say these maintenance therapies have really helped not only increase patients' overall survival, but again, increase the time between interventions. And the maintenance therapies, are really designed to decrease the toxicities and the side effects and make it really acceptable for somebody to be on one of these therapies for quite some time.
Before I open it up to questions, because I know there's going to be a lot of questions, I do have one more question for you. And maybe talk a bit more. You alluded to it, your research project was on it, but the BRCA mutations, which most people know increase the risk of breast cancer, but obviously it increases the risk of ovarian cancer and other cancers. Maybe talk a little bit about women who have a BRCA mutation who don't have ovarian cancer and the role for surgery in those women, but also for women who find out only after they've had ovarian cancer that they have the BRCA mutation. Maybe talk a bit about the role of the BRCA mutation in evaluating and treating patients.
Absolutely. So part of the work of an evaluation for anybody that's been diagnosed with ovarian cancer is a full genetic evaluation. So we go ahead and test that person for there are a known handful of genes, including what's called BRCA1 and BRCA2, and some others that would predispose women to the development of ovarian cancer and other kinds of cancer. And again, like you alluded to, BRCA1 and BRCA2 put women at risk for ovarian cancer and for breast cancer. So typically what we would do is we would test the affected individuals. So for example, if a patient were referred in to see us, they would have a diagnosis of ovarian cancer. We would recommend and offer them a genetics evaluation where they go and meet with a special cancer specific genetic counselor that would offer them a wide variety of tests to evaluate for any sort of genetic component. And then oftentimes, if that person is positive, then their children would be offered testing. And we would test both men and women because there is a 50% possibility that if a person who has ovarian cancer is positive for one of these genes, especially BRCA1 or BRCA2, there's a 50% chance that that gene could be passed down to their child, be that individual a man or a woman. So in the men, they would be at risk for breast cancer if they tested positive, and the women obviously would be at risk for both breast and ovarian cancer. And finding out that is really helpful, because even if a woman is like, well, I'm not ready to undergo a prophylactic mastectomy, and I'm not ready to undergo a prophylactic removal of the tubes and ovaries, because they want childbearing or because they're just not in that space yet. That's fine. There are ways that we can screen once we know somebody is at high risk for the development of ovarian cancer and or breast cancer, then we can put them in a screening program. And we've had really good success on monitoring women. And then once they've decided they're done with childbearing, then we would talk to them about having a surgery to remove both the tubes and ovaries, and then possibly the uterus as well. And then Some women, obviously, as they progress through, may want to go ahead and decide to get a prophylactic mastectomy, and we have a whole team that will help with all that sort of thing. So that's just a little bit about the preventative maintenance that we do. So,
Yes, and I also add that pancreas cancer is also one at risk, and
yeah,
right now, we can do prophylactic. You can do prophylactic oophorectomies. Our breast surgeons can do prophylactic mastectomies. We so far are not doing prophylactic Whipple pancreatectomies.
we're not. But again, depending upon the genetic makeup and what the patient is diagnosed with, then we would put them on some kind of screening program, which may
Mhm.
be, CT or MRI evaluation of
Yeah.
whatever organ that they're at risk for developing a cancer in. And then usually, again, these are caught very early with frequent screening and can really lead to decreased risk of death if we discover these things early. That's the key, is identifying them early. So I would say, even if somebody is diagnosed with a certain genetic mutation that would put them at a high risk, that doesn't mean that they have to go and have a surgery. They just, we would recommend that they enter into a screening program, and that we'll keep an eye on them. And then as the future unfolds, they may decide at a future date to have some surgery to prophylactically remove
Yeah.
some organs based upon their age and their childbearing and things like that. There's a lot that goes into it.
And for those at high risk, we won't go into great detail, but we've covered it on this show before. There are new screening tests, blood tests looking for circulating tumor DNA that may end up playing an important role in screening some of the cancers that we don't have valid screening tests for now, such as pancreas or ovarian, and
Correct.
that research is being done right now.
Right, right. And then just really quickly, I just wanted to make one comment about endometrial cancer. So all women with endometrial cancer are screened for what's called Lynch syndrome, which is hereditary endometrial and colon cancer. Because just like you had said correctly, that there are certain cancers that run sort of together, like breast cancer and ovarian cancer. That is true for endometrial and colon cancer as well. And that condition is called Lynch syndrome. And there's a very specific set of genes that can be altered in patients with Lynch syndrome. And again, we universally screen everybody that walks through the door that has a diagnosis of colon cancer is screened by the colon cancer doctors for Lynch syndrome. And if they find somebody with Lynch syndrome, they would send them to us to talk to them about their uterus, and vice versa. If we find somebody that has Lynch syndrome, we would send them to the GI doctors to have more frequent colonoscopies to be evaluated for that. So the universal screening for ovary and breast and uterine and colon are
Great.
relatively effective in helping to determine this high risk population, and then keep them safe from harm.
Great. We're going to open up to questions. So if you're watching us live streaming right now, you can place your question in the comments section of the software you're using to watch us. But we've got a large live studio audience. They're going to get first shot at questions. So we'll start in the back row.
Hi, I was wondering what the recommendations are to get a pap smear.
Yeah, so that's a good question, and I hope I don't stumble too much, because I will be honest. I I do not do any screening pap smears, because I unfortunately see patients on the back end. But so I'm going to take a stab at this, but I'll have to maybe look this up and get back back
Yeah,
with you.
you know what? We can take you off the hook for that one, because I just did a talk on the guidelines,
Yeah,
and I will provide you, and really the important thing to just answer is having a very good primary care doctor with electronic medical record that keeps track of all of the guidelines and when you should have your screening. But let me turn it back to you, and you can just talk in general, realizing that
yeah.
the guidelines change and how many times, how often, and what age do vary a little bit. But I'll turn it back to you.
They do. I'll take a swing at this, but I want to say, and don't hold me to this, but I want to say that it's usually by, I want to say, age 18, or right when the person becomes sexually active. You should go ahead and start having a pap smear, and then usually it's yearly after that, up until a certain age. probably in your, I'm going to say 60s, 70s. But again, I'm sorry, I'm embarrassed. I do not know because I don't provide any of these screening services. Unfortunately, we see patients after they've unfortunately been diagnosed with that, with a cervical cancer. But like you said, Dr. Deming, a good general medical doctor should be all over that.
Yeah, just like parents shouldn't have to memorize the entire vaccination schedule.
Yes.
That changes. So guidelines change, and having a good primary care doctor is the key to screening. Next, Gary.
Yes, I've had a couple friends that have passed away from ovarian cancers, and I had heard that at one time that baby powder, talcum powder, may have been a cause to, for those cancers to develop. Is that true?
Yeah, that's a really great question. So, as it stands right now, there's no direct evidence that baby powder or talcum powder or anything like that, directly causes or leads to the development of ovarian cancer. Um, we know that there are some risk factors for the development of ovarian cancer. The main one being, having a genetic alteration, having a first degree relative with ovarian cancer, and then again, having an early stage or a early diagnosis of breast cancer at an early age puts that person at risk as well. But to my knowledge, the talcum powder thing has never been really fully proven.
Okay, thanks. Next question. Pearl.
Hi, can the cancer be like basically ovarian and endometrial cancer? Can that be accompanied by blood hypercoagulability, where the platelet count increases? And so, could that be a factor or a mechanism to use that as a sort of diagnostic tool for screening purposes?
Yeah, that's actually a very good question. So what you're basically asking is, can an increase in platelet count be used as a screening tool? And typically not, because there are so many other reasons why somebody could have an increased platelet count. And the reason why platelets increase during cancer diagnoses are vast, but usually because the platelets are what's called an acute phase reactant, and they elevate oftentimes when somebody has a cancer, and then sometimes they stay elevated and sometimes they don't. But the having a high platelet count necessarily wouldn't make you hypercoagulable. The reason why you're hypercoagulable if you have usually almost any kind of cancer, and especially a gynecologic malignancy, is just because the tumor, the cancer itself, makes certain compounds that would make that individual predisposed to development of blood clots. So just because you have a high platelet count doesn't necessarily mean you're at risk for a blood clot. And there are so many reasons why people have high platelet counts that it's just not a very good screening test. But that's a very good question.
And Dr. Goodheart, would you say that most individuals with cancer who do get clots have normal platelet counts?
That is a correct statement. I agree. So most people that get clots do have normal platelet counts. Yes.
Okay. Next question.
Yeah. Hey, so doctor, with your long experience and the research that you have done so far, what would you say are the top reasons for gynecological cancer, like ovarian cancer, uterine cancer, or cervical cancer? And if that person's BRCA gene test 1 and 2 came as negative, and my second question is, post surgery, what are the steps that person needs to do to prevent an ovarian cancer? Because you mentioned that the recurrence rate for ovarian cancer is really high.
Yeah. So I'm going to take the second part of your question and answer that first. So your second question was basically, if somebody has an ovarian cancer diagnosis and they get operated on and then they get chemotherapy, what are some of the things that are done to screen for them a recurrence or prevent them from having a recurrence? And lots of times what we do after somebody has completed all of their therapy, surgery and chemotherapy and everything, we have sort of kind of like a wrap up visit with them. And at that visit, we talk about, where they've been, what they've gone through, and then where do we want to go moving forward. And there are different indications for putting somebody on a maintenance therapy, which would be, again, given to decrease the risk of that cancer coming back. And even if that person is not a good candidate for maintenance therapy, because we just don't have any evidence that a maintenance therapy would work for them, then we do screen patients very carefully. And what we would do is typically see that individual every 3 months for 2 consecutive years. And then after the 2 years, we would bump that individual to visiting with us every 6 months for 3 more additional years. And during that time of the observation and follow-up, we would be very carefully talking to them about symptoms, asking about any bowel or bladder issues, any early satiety, any abdominal bloating. And we would also check their CA-125 because, again, although a CA-125 is not a good screening test for the general population, it is a very good test once somebody has a known diagnosis of cancer, because what we hope is that CA-125 goes down to normal, and then we can use that as a way to screen patients when they come in to visit with us every 3 months or every 6 months after the first 2-year mark to go ahead and screen for them to see if they have an elevation in their CA-125. Then we would go ahead and scan them, do a CT scan, and then kind of go from there, whatever findings we have. And then the first part of your question, could you just repeat that one more time? That was about detecting different cancers.
I think it had to do with what are the risk factors for.
Yeah, the first part of the question was like, with your research, what have you understood are the top reasons for any kind of gynecological cancer when the BRCA1/2 tests came as negative?
Sure. Yeah. So for ovarian cancer, the risk factors are mainly hereditary. So if a family member, if a first degree relative has a cancer, then that's a huge red flag, or an early age of diagnosis for a breast cancer. That would be a big red flag for that. For uterine cancer, the biggest risk factor would be obesity. Definitely puts people at increased risk. Diabetes does as well, and any kind of unopposed estrogen. So if somebody's on tamoxifen for breast cancer prophylactic, which sometimes happens, tamoxifen is a medication that acts as a proestrogenic medication for the uterus, and sometimes we see women that unfortunately are on tamoxifen that are predisposed to endometrial cancer formation as well. And then lastly, for cervical cancer, the biggest risk factor for that is infection with the HPV virus, which is spread through sexual contact. That is by far the biggest risk for the development of cervical cancer.
So, Dr. Goodheart, in the University of Iowa Public Health has put out a notice on nitrates, and that nitrates, and we're looking at all ag chemicals, but nitrates in particular, increased risk of endometrial cancer with nitrate exposure. And then I have seen some other information about other ag chemicals, insecticides, pesticides, herbicides, increasing the risk of some types of cancer, including gynecologic. What is your Gynecologic Oncology Society? I mean, do you guys have some thoughts about those environmental exposures leading to increased risk of gynecologic cancer?
Yeah, that's a great question. So, I don't think there's an official statement out from the Society of GYN Oncology about pesticides or any kind of nitrates or anything like that. But, from my time that I spent in Louisiana, definitely Cancer Alley is the section along the Mississippi River where all the petrochemical plants are, and there's a huge incidence of cancer along that strip of the Mississippi that runs basically from Baton Rouge down to Louisiana, or I'm sorry, down to New Orleans. And I would say, Iowa has a very high, I want to say we're second as far as states. And, the idea is because, this is a hugely agricultural state, and there are a lot of pesticides and things like that that are used in farming. And we're actually in the process of looking at some of those things to sort of determine, are there any little pockets, within Iowa for any kind of gynecologic cancers where there's an increased risk of developing a cancer if they're, near a farming community. And again, there are so many farming communities that's maybe going to be a little bit difficult to tease out. But I definitely think there's a relationship, and it sounds like that's just being kind of shored up and firmed up a little bit more. As far as any kind of, public statement or any announcements or recommendations from the Society of Gynecologic Oncology, which is sort of our governing body, I don't know of any of those currently right now.
Okay. Well, I am afraid to say we are completely out of time.
Oh boy.
And our guest has been Dr. Michael Goodheart, gynecologic oncologist at the University of Iowa. Thank you so much for being our guest. And if you in the audience, either in person or those of you watching us live streaming, know someone that would benefit by watching this program, it will be available for viewing on demand beginning tomorrow at the Above and Beyond Cancer YouTube channel or the Mercy Cancer Center website. Thanks for joining us. I hope you join us again next week. Thanks, everyone.